All right, so it's actually very special for me to talk today, not because of the talk in a great institute that led by Dr. Khadim Hashemi, but also the talk actually hosted by a great person who has been inspired me over the last 10 years or more. So I'm really super excited and very nervous for last few days because I have, I don't know when I have really dreamed that I'd be able to talk, and that would be hosted by Ali. I'm a new faculty here at UTEP, University of Texas at El Paso. I started 2019 September, which is like maybe 10 months from now. But I'm very fortunate that I had a great start, but because of this pandemic, we have been out of lab for last 4 or 5 months, but still we have been able to make a significant progress. My lab has now 12 members, including 4 PhDs, couple of PharmDs, masters, undergraduate, and technicians. And so that I'll be talking mostly about my, postdoc work and also some new works that I continued in my lab. So my name is MD Nurul Nabi. I go by Nabi. So I did my undergraduate in Bangladesh in pharmacy, and then I thought to do research instead of being a pharmacist. And then I did master's and PhD in South Korea. And part of my PhD thesis has been completed at University of Utah, 2013 to 2014, that I will talk a little bit. And then I did my postdoc at Harvard Medical School. And then later on, I moved to Wyss Institute and School of Science and Engineering under Professor Mitra Goti. So before going to introduction of my talk, I want to give a background. So I met Ali 2013 May at KAIST in South Korea, and that was my kind of very early stage of my PhD. And since then, actually, I had my full kind of motivation and kind of dream to work in an industry. And but I attended his talk and we chat for a couple of minutes. And that was kind of turning point for my life to start dreaming to be a faculty, especially in US. Since then, Ali has been a great inspirational figure to me. He has been super supportive, although I never had a chance to work in his lab. But I got like full support from him. Starting from recommendation letter, career suggestion, advice, and career development advice, and whatnot. Then I met Ali in 2017, a year after I moved to Harvard at Wyss Institute. We did probably a few days before Ali was planning to move to UCLA. So I always acknowledge this kind of inspiration and motivation, although it's not like full time, but whatever I got from Ali, it helped to change my life, and probably that has played a critical role to put me where I am now. So that made me emotional, but let's forget about that. Let's get to the research, that the reason why we are here. So as you have seen from the title, that we're going to talk about diabetes and obesity. The diabetes is one of the very common problem nowadays, regardless of the geographical barrier. So long time back, diabetes used to be a disease of the rich people who doesn't do the hard work, right? Because if you don't do hard work, it result in increase your body weight, and then that kind of play a vital role in increasing the glucose level in the body, and that is the readout of diabetes. So the diabetes is the excessive glucose or sugar level in the blood. So in a healthy patient, we have the pancreas that supposed to produce enough insulin that needs to metabolize the glucose that you uptake. But when you see that insulin secretion is not adequate, that means there is lack of insulin, and so that you see the excessive of glucose level, which called type 1 diabetes. So that we need to give insulin from outside of the body, right? So there is another treatment, which is some other small molecule drug, but actually insulin is the most common, because when the small molecule drug get resistant, you have to start insulin, and then you have to increase the dose day by, year after year, because that also get resistant at certain time points. So you probably start at single dose a day, probably then go 2 times a day, 3 times a day, and it sometimes even get like 10 times a day if it is long time. Just for an example, my grandmother, who has suffered like 30 years in diabetes, I have witnessed her suffering, and then it is like super painful to get like 7 times subcutaneous injection every day, and that not only painful but also cause inflammation in the stomach, in the skin on the stomach, right? So then there's other diabetes, which is called type 2. So type 2 diabetes is a little bit different, whereas you produce enough insulin, but the receptor is damaged because of the cell damage, or it could be chemical contamination or the drug side effect, or it could be the cancer, pancreatic cancer, or many other reasons that actually play a vital role in type 2 diabetes. And one of the main reasons of type 2 diabetes is actually obesity. So that I designed this talk on treatment of type 2 diabetes and also prevention of type 2 diabetes. So there is 2 major chapters, and most of them are published. And also we'll talk a little bit about our future direction, what we are planning to do or what we are doing in our lab. So like we listen a lot about cancer, cardiovascular disease, but probably we get less into the diabetics, because this is not kind of certainly that you are dying like because of cancer or stroke or heart attack. That highly likely patient are dying, right? So there is very less recovery rate, very less chance of someone to survive or get back to normal. In diabetes, this is a slowly killing, like poisoning, right? So you get diabetes slowly, and then it gets like severe, from acute to severe, and at certain time point we lost our immunity, and because of that we get lots of infection, or even very minor seizure in our body that takes long time to get recover. And if we had an accident, that doesn't get healed normally because of excessive amount of glucose in our body, in our blood. So there is a stat that I pull out from the different source. So it is like right now 7th leading cause of death worldwide, right? And only in US there's 30 million of people are diagnosed as diabetes, which is really huge compared to the population in this country right now, right? And 1 of 4 are not aware, which is actually more scary. Probably, for example, I didn't go to doctor for last 2 years. So I don't know if I have the diabetes, right? Because I didn't check my blood glucose level. And like me, there are thousands of people or millions of people in US who doesn't know if they have, the acute diabetes state. So that is actually scary, even the people who diagnosed, because the people who diagnose, they can take the precaution, they can control their lifestyle, food habit, and maybe they take medication if needed. And there is 80 million of young adults are risk. So this, these 80 million people are actually the number that's gonna reflect probably after 10 years or 20 years. So in they're gonna be our real workforce, right? So those young adults are mainly because, look at our childhood. We used to play in the playground, outside, do the biking and other things like soccer, badminton. Nowadays, the kids are playing more than we do, but they are playing in their screen like computer, iPad. So that actually making a big impact in their physical ability or health and sustain. And another reason is that those kids are getting lots of unhealthy food in their school. They're eating like pizza, sandwiches, lots of cheese, and soft drinks. So that, childhood obesity, the reason of childhood obesity actually the less physical activities and also consuming that those like unhealthy food that we did not take when in our childhood. So these 80 million, young adults are going to add up with this 30 million after maybe 10 or 15 years, and that's going to be, very devastating in our healthcare sector. So, and that can actually, so as I say, 90% of them are not aware that they have the diabetes, and actually, increase threefold in 20 years. So, as day by day, we are getting more used to about those, like doing less physical activities. We are doing lots of work in computer. We are using lots of artificial intelligence, robotic system in our agriculture, in our daily work, house cleaning, or vacuum, everything. We are actually kind of doing less physical activity, and that's gonna result threefold more increase in 20 years. So today, I'll talk about, kind of oral delivery of those insulin and those large molecular peptide that used to treat those diabetes, type 1 and type 2. So why we choose to do, oral delivery? Because over the 90% of the people, if you do survey at your home, in your school, in your class, even in a lab, more than 90% people actually hate injection. There are some people who are brave, they don't care about those like small pinch or pain. But in most of the cases, like overall 90% of the total population are more favor into oral medication than injection. This is a convenient of dosing and also patient acceptance, right? But if you see the real stat in the market, there is only 50% of the total drug are actually oral forms, which was actually more before. Like there was 80% of the total drug, even 10 years back, which is oral medication. But nowadays, the large molecular drug or the antibody, peptide, protein, enzyme, those drugs are getting more popular, so that those oral medication are getting less day by day. So as you know that those large molecule, like those are sensitive in acid and which are not stable in stomach, are always recommended to injectable, right? Not oral delivery. So like most of the biologics. So I'll talk a little bit more about that in next slide. So like most of the diabetics drug, cancer drug, vaccine are actually injectables. So why we can't take those large molecule or biologics orally? So there are multiple reasons. Number one is the acidic condition in the stomach. So most of the biologics are not stable in acidic condition. They kind of dissociate or proteinase. The acid means there are lots of protein, and that can change their chemical structure of the molecules, and they completely get a new form of the drug, right? And then other thing is that because they are really large molecule, they don't penetrate the epithelial barrier in the intestine, and they're not able to get into the blood circulation. And so there are multiple barriers in the intestine, right? There's a mucus layer. There, like number one is tolerance, that means acidic condition. That mucus protection, penetration. So there is a mucus barrier, right? That's actually protect our endothelial and epithelial cell in the intestine from the acidic condition. And there is a kind of, if you go to the second layer, which is tight junction between those endothelial cell, only probably the small molecule, which is like 400 Dalton, 500 Dalton, are able to penetrate those junction, but not the large molecule. And then the drug has to penetrate the PMN recruitment and then penetrate the epithelial barrier. Then they would be able to go into the blood circulation. Then you get the effect, right? So there are actually lots of barriers that a drug has to overcome to be able to get into the blood circulation to give the the pharmacodynamics, which is therapeutic effect. So if you look at what happened when you give a normal drug in the blood circulation, so for example, if you give a large molecular drug orally, they don't penetrate. But if you make a micelle with the large molecular drug, here we put an example of heparin, and then we put a conjugated deoxycholic acid, which is hydrophobic, and heparin is a hydrophilic. If you put into the aqueous solution, they make a micelle. And then if you took a micelle put orally, they kind of interact with the bile acid transporter in the endothelial intestine, and they've been able to kind of get into the blood circulation. So here we put GLP-1, which is the type 2 diabetics treatment large molecule. It's a glucagon-like peptide, but because the glucagon-1 peptide is half-life is very short, so we kind of modified that GLP-1, and also we encoded plasmid DNA into it to give it more sustainability, more enhanced therapeutic effect. So if you see the function of GLP-1, it has actually great application not only in the diabetics, like insulin biosynthesis, beta cell proliferation, beta cell apoptosis, which is great to treat type 2 diabetics. At the same time, they actually send a signal to the brain that helps to lose appetite. That means we don't feel hungry, so that we uptake less food. And there is also other application like cardioprotection, which actually helps the heart to be more healthier, and also liver, right? So there are multiple applications of GLP-1, but we're going to focus only on the obesity and type 2 diabetics. Obesity means uptaking less food, and also enhancing insulin secretion, right? So what we did in our project, so in this case, we took PEI, which is branched polyethylenamine. This is highly cationic charged polymer. Then we took the GLP-1 peptide plasmid, and then we mix together. The GLP-1 is a highly negative charged molecule, and then PEI is highly cationic, which is positively charged molecule. If you put together in different ratio, you're gonna be able to get different size of the particles, because they're gonna be charge electrostatic interaction between the negative and positive. And you see, we got 15 to 20 nanometer particles of this complex. Which is not enough to get into the oral absorption. So that what we did, we took heparin as a carrier, and to protect that molecule from the GI tract acidic condition. And we took TCA, tyrosine acid, which is a bile acid, so that you can enhance the oral absorption through bile acid transporter in the intestine. So finally, you get a really 100 to 120 nanometer particle that has the So that has a outer surface has tyrosine acid, which is a transporter enhancer. The heparin, the yellow one, is a protection or shielding, and then you will see inside of the core there is GLP-1 and branched polyethylenamine, which is actually complex. They're holding the GLP-1 inside of the core of the nanoparticle. which is like 100 to 120 nanometer. We control the size different depend on the feed ratio. Like in this case, 1 to 2 is more appropriate, like as we expected. And with the gel electrophoresis, we confirm the presence of plasmid DNA within the particles. So then, to confirm that plasmid DNA like expression in the cell, we actually switched to GFP, green fluorescence protein, into that GLP-1, so that we'd be able to detect them by fluorescent microscope. So we made a Caco2 cell monolayer to see if this nanoparticle are able to kind of penetrate that monolayer, which is kind of mimicking the intestinal membrane. So it shows that the particles itself, with the GFP1 are very efficient of expression of the gene in the cell. And you see the figure B, where we also kind of coated the membrane with rhodamine B to be able to see where the membrane is going, where the polymer is going, right? So we see that their coexistence of GFP and the membrane within the cell. And in some cases, those GFPs are actually in the nucleus, if you see the magnified image here. Which is great. Actually, that's what we have been expecting, that that the polymer actually be able to release the GFP1 that has been entrapped into the nanoparticles. And then in C, we made the monolayer of those Caco2 cell, and we put the particles on top of that, and we collected the solution from the down, so that the reason of this experiment is to see if the particle actually penetrating that in the Caco2 cell monolayer, which is again the mimicking the in vivo system. So you see, if you go to the figure D, we see the presence of the GLP-1 in the they are in the cell. So that means they are not only penetrating through the cell junction, but also they are penetrating through the cell, right? So it's which is great. So we also use HepG2 cell and also NCI A716 cell. So HepG2 is a liver cell. So we tried with the Caco2 cell, we tried with the HepG2 cell, and NCI A716 cell to confirm that it works and it penetrates the cell membrane, and also it sustain within the cell to be able to enhance the insulin secretion. So then we took that, as you have seen, that we decorated the particle with rhodamine B. In this case, we actually coated Psi 5.5, which is near infrared dye, to be able to see how they are staying into the GI tract and where they are getting absorbed and what is the PK or biodistribution, right? So you get, you put the, this formulation orally, and you do the IVs imaging over the time. So within 20 or 25 minutes, they are highly present in the GI tract. So it seems like they are in the intestine, small intestine, and they stay in the intestine for 24 hours. So, which is very difficult to identify where they are exactly from figure A. So we kind of harvested the animal and took out their GI tract or other organs, including kidney, lung, spleen, heart, and stomach. So you see, the high intensity observed in ileum. So the reason you see highly intense in the ileum, because the bile acid transporter is highly present in the ileum, and our nanoparticle actually designed to interact with the ileum in the intestine, right? So, which is a great, the evidence that our particle is highly target specific. That means they are really binding with the bile acid transporter and enhancing the oral uptake, and that kind of leading the oral absorption. So if you see in the figure C, where we kind of took the tissue and then section them and put under the microscope to see where they are exactly. So they are in the liver, they are in the ileum, and you see the green fluorescence that kind of give you the evidence of the presence of GFP or the GLP-1 plasmid in the different organs. So we don't see many things in stomach, and we don't see much in spleen, which is great. That means they're gonna give you the less toxicity or inflammation. And then we also did quantitative analysis of these data to see how much is there. So actually liver shows high uptake, because if you see the mechanism of bile acid, so when the bile acid uptake in the ileum, and they go to the liver, and again liver secretes the bile acid, and it kind of recycle through the ileum, small intestine to liver, and liver to small intestine. So that's what happened in our body. So our body, in regular basis, circulate like few milligram to gram of bile acid regularly. So this is actually the bio-inspired drug delivery system that we designed. And later on, we kind of took the type 2 diabetes model. This is mouse, and then we injected or orally administered GLP-1 formulation, and we do the histology to see where the GLP-1 is present, and also we did anti-insulin antibody staining to see if our GLP-1 actually enhancing insulin secretion in vivo system, right? So if you see the figure down to panel where we have the nanoparticle with the GLP-1, that has more presence of insulin than only high-fat diet, which is the second panel, and also normal diet. So in normal diet, the insulin is like, which is normal, but high-fat diet, the insulin level is super low because, see, they are taking lots of fatty food, and the animal is not able to produce enough insulin to kind of metabolize that glucose. That's why you see very less insulin presence in high-fat diet, more animal. Whereas, in last two panel, you give the high-fat diet, but at the same time, you are giving the oral dose of this formulation, you see high insulin presence, because this oral insulin actually influencing of excessive amount of insulin secretion. So we got patent of this work in 2016, and now we formed a biotech company based in Salt Lake City named Elio Bioscience to be able to translate this product to the commercialized process, right? So I'm going to give you more details about what we got from this study in terms of in vivo. So we take the formulation, put in a small kind of capsule, and give the orally, and then you give this drug orally like twice in a week, like every 5 days or 4 days, and within 7 days we've been able to reduce the glucose level in the normal state. The gray line is the normal range of the glucose level. But if you are not treating the animal, they are kind of, the glucose level is really very high, and they are very constant. So that we say, if you give a drug of this formulation, like once in 4 days or 4 times in a month, or 8 times in a month, so you'd be able to kind of control their blood glucose level instead of giving these once in a day or twice in a day. So that we can say probably this formulation not only actually enhancing absorption of GLP-1, but also they are controlling the release of GLP-1 from that particle, so that they are maintaining the blood glucose level for a certain period of time, which is great that you can actually reduce the doses frequency for a patient if you can able to translate. And we found another great finding, which was expected, because GLP-1 has loss of appetite effect. So when you give these orally, 8 times in a month, which is like twice a week, and they lose their body weight almost like 10% within a month. This is kind of, 100-pound human can get into 9 pounds, so that without any exercise or without controlling their food, so that that gonna actually make a synergistic effect with the high accelerator of insulin secretion, and also losing body weight can give you the sustainability of the therapeutic effect. I'm gonna show you another study concurrently occurred in Professor Mitragoti's lab. This is my postdoc mentor, Sami Mitragoti. Many of you know, who is a role model of many people, and also he's a pioneer of many oral drug delivery and transdermal drug delivery system. He's not only great scientist and mentor, but also supermodel. You see here the way he's holding the capsule and the needle, where he is giving a message that we're gonna convert the injectable into the capsule, right? Which he formed a new company in Boston. I think early of this year. 2 of my colleagues are working in this company, and then who has been my lab member in Mitragoti's lab. So, and they also raised like $4 million to develop this biological drug. And the company name is I2O, that means injectable to oral, which is very creative, very exciting about this. So they developed, Dr. Mitragoti developed, ionic liquid. So this ionic liquid composed of choline bicarbonate and uranic acid. So the beauty of this ionic liquid is, this is highly hydrophobic, and so that, and also it actually, make a passes through the mucus layer and endothelial layer in intestine to facilitate this large molecule to get into the blood circulation system. And it is made with choline bicarbonate and uranic acid, which is a biomolecule and bio-inspired material, so they don't have any visible side effect or toxicity. What they did, they took this ionic liquid and added insulin, because insulin is liquid, this ionic liquid is also liquid, and they mix together in different concentration and put orally. You see the pharmacokinetics. Whereas if you give insulin orally without ionic liquid, you don't see them in the blood at all. But with the ionic liquid in different concentration, they give like intrajejunum and subcutaneous, and you see them in the blood, right? Which is great. So ionic liquid actually kind of enhancing the concentration, which is equal to subcutaneous. The red line is subcu, and blue is the case in intrajejunum. So they give the pharmacokinetics, and then later on they see the pharmacodynamics, which is the therapeutic effect. So they see right. So they see in the changes in blood glucose level percentage. So you see the the green line, which is 10 unit kilogram per insulin case. It shows the really significant result, reduce the blood glucose level to the normal level with single dose, and which is actually better than sub-Q of 2 unit. So the reason we are giving it has given like more than 5-fold, because you see there is a loss in the oral delivery, whereas if you just inject in the blood, you are getting like 100% PK. All right, so there is no loss. So you would be able to, when you're converting injectable to oral, you have to see like what is the dose you need to give orally to make a equal pharmacokinetics of injectable or subcutaneous. So that's what we did here. And then depend on time. So you see the blood glucose level is changing like within 2 hours, 4 hours, 6 hours. It's very constant and very sustainable. So one of the great findings I noticed from this study is that, so when you are giving hydrophilic drug, with the case, they are enhancing absorption, but at the same time, if you're giving hydrophobic molecule, one of the example is here, coumarin 6, like the more case you increase, the more increase you case is, choline and uronic acid, ionic liquid. So, they kind of reduce the oral uptake of the coumarin 6, which is hydrophobic. So based on these findings, we thought, okay, this molecule actually enhance oral uptake of hydrophilic molecule, but it does not enhance oral, actually it prevent oral uptake of hydrophobic molecule. Then we thought, okay, how about like cholesterol, fat, which are hydrophobic molecule as well? And probably we can use this ionic liquid to reduce body weight by reducing fat uptake when you are eating fatty food like cheeseburger, the cholesterol and many things. So so there are multiple reasons of people become obese, right? People get diabetes, obesity, excessive food uptake, sedentary, stress, family history, increasing age. But we thought if we use the case, we could actually address at least two things. One is obesity, another is excessive food. I don't know, people may also get stressed because of the obesity. I think people get, that's why they are very up to, how to reduce the body weight, how, doing keto dieting, doing lots of exercise, which is great, but some people really get stressed because of those body shaming and then other, societal factor they are facing every day because of the bulky body, right? So I think we could at least address a couple of issues if we can reduce the fat uptake. So if you can actually reduce the body, obesity, you can actually address many things, like 80% of the total adult, as I said before, and those obesity actually also resulting cardiovascular disease, the arthritis, and there is also cancer that related to the obesity. So not only diabetes, right? So we thought this is going to be a really great findings if we can do that. So there is a nice video I want to just show for a few minutes.
Francis is known for his discovery, along with Tim Watson, of the structure of DNA. And he would occasionally indulge in a double bacon cheeseburger. Person is only 2,000. This would be more than half your daily required carbohydrate and fat, and eat all of it. And I'm going to take you on a journey as we take a bite of food and watch as it goes through our bodies from the outside to the inside and what happens to it. And it goes through a series of scripted events. Here's the bite of food that through chewing is broken up, and then through biochemical events begins to be further processed in our bodies. Here it is in our stomach, where it's beginning to break up into its components. The little yellow droplets there are the lipids that we're going to track in more detail. From our stomach into the intestine, where absorption of nutrients occurs, and here I repackage it on the inside into something called chylomicrons, ultimately to the bloodstream, where this packaged fat now is delivered to tissues such as the muscle, where it can be used to burn energy, as is shown here, or the excess that is not burned. Remember, the fatty stored in and delivering the excess energy where it's going to be stored in fat.
So,
Francis,
so so this is a video shows that when you take a cheeseburger or cholesterol or cheese containing food, so the excessive fat actually stay located in the adipose tissue, and that result our the increment of the body weight. So there has been two drugs FDA approved, orlistat and lorquix. So that actually helps to reduce body weight, but those have severe diabetes, like if you, severe toxicity or side effect. So if you take this drug, probably you have to be in the bathroom for a couple of hours or a couple of times a day because that caused the diarrhea. So, that was one of the concerns that we don't want to face every day, in terms of reducing body weight. So what we we took this ionic liquid as a proof of concept. So what is containing in our stomach? Our stomach has lots of water, and which is kind of the kind of bile acid, and you have you take the fat, right? So the fat is from the food. So we took the case we took the fat, which is the DHA, is an omega-3 fatty acid, and we took add water. So you see, as soon as added water, they like within a second they transfer to opaque, like solution. So that actually give us a very concrete evidence that this ionic liquid could be used for kind of preventing fat uptake, because when you take this kind of yogurt-like solution and put it in a microscope, you see they are forming really large molecular particles, which is like 5 to 7, even sometimes 10 micrometer particles, and which is never gonna penetrate the GI tract. So that idea is to, taking the ionic liquid when you're taking the food, and then this ionic liquid gonna trap the fat, and they gonna make a large molecule large particle in the intestine, and they're gonna excrete to fasciculation instead of going to the blood circulation. And also we did the diffusion with the intestinal membrane to see the diffusion prevention. The blue one is actually shows that our ionic liquid prevent the fat diffusion through the to the intestine. So if you take the fat, normally without any ionic liquid, they goes and uptake in the intestine very rapidly. But with the ionic liquid, it's actually prevented. So to do the real animal study, we took 4 groups of animals. So one group is regular food, another group is got high-fat diet, which has 40% more fat than regular food. Another is high-fat diet and got like 5 microliter, which is very tiny amount of ionic liquid orally. And another one is high-fat diet and to get 10 microliter of ionic liquid. So regular food taken group, they increase their body weight like, maybe 1% or 2% per week. When you are getting the high-fat diet, they are increasing like every day 4 to 5 gram body weight, which is like really, really scary, right? And then when you're taking like 5 microliter of ionic liquid, you don't see any significant changes in the body weight. But when you're taking like 10 microliter ionic liquid orally with the capsule, you see really significant changes with every animal in the group. So you see here is like only 3, but really in the experiment we did 5. So this is the graph you see here. When you're taking ionic liquid with the fat, they stay in the intestine over 6 hours. And if you take only the fat, the C6 mean coumarin 6 was leveled with the fat to be able to detect them in the body. So they don't stay, right? So without ionic liquid, the fat goes to blood circulation, and you can detect their presence from the plasma. And also we did, took all the tissues and see where they're going into. So if you take like, DHA with the fat, fat with the ionic liquid, they prevent the fat uptake, whereas only fat goes to the blood circulation and presence in the different organ and blood circulation. So after 30 days of the study, we found that 13% body weight reduction in the treatment group of 10 microliter. And also you see the less food uptake, which is almost 15 to 17%, sometimes 20%. So that because the fat actually staying in the intestine, that's why they lost their appetite, and those animal actually taking less food. And we see the choline because we are using choline, and we want to see if the choline in the body. So the choline is a biomolecule, so our body has already choline. So the untreated group, that means they are not given the case. So still the black one, you see the presence of choline, whereas the treatment group shows like very equal or very similar amount of choline. That means choline is not going into body. So there's actually no risk of any toxicity. So in terms of toxicity, we also check if we see any significant changes in low density lipoprotein, high density lipoprotein, total cholesterol, and whole body fat content. So the green one, which is the 10 microliter oral delivery, shows less fat content and less low density lipoprotein, whereas we see not much difference in other HDL and other things. So we also see the lean tissue by micro MRI. There is not difference in lean tissue, and we don't see any significant changes in the blood count, white blood cell, red blood cell, and platelet, because they are not in the blood. And also we see the serum biochemistry, different biomarker to see if they are causing any toxicity in liver, kidney, or any other organs. And also we did histology that we don't see any significant sign or symptoms of toxicity. So, given that in our lab right now, we are focusing on multiple disease like inflammatory bowel disease, because you see they are in the intestine for a long time, so that we see it has a great potential of delivering sustained delivery of the drug in the intestine, and also ulcerative colitis, Crohn's disease, and we're gonna focus on polycystic ovary syndromes because that is more related to the obesity. The aim of my oral delivery research is to converting all the large molecule, including siRNA, DNA, peptide, antibody, convert as a capsule form and given orally, so that treating pain should not be painful, so that we don't want to get pain to treat the disease of the pain. By saying that, I want to really acknowledge my great mentors, who has been played great role in my transition and training. Sami Mitragoti is a great personality, a great mentor, and a great scientist. My PhD and master's supervisor, Professor Youngpil Lee and Yuhan Bei at Utah. And right now, my lab has those members working in the lab, very energetic and highly motivated people in the lab. I'm very glad and proud for that. And my lab actually recently got funded, which is very exciting too. Within 5 months of my starting lab, I got extramural funding from a foundation. And I also have a startup funding from university and graduate school. By saying that, I'm ready to take question. And again, thanks Ali, Mehmed, for giving me the opportunity to talk. And I didn't hear the introduction, so I don't know much about, did you say anything bad about me? Thank you.
Thank you for the talk. No, everything was great about you. Don't worry about us. Everything was excellent. So thank you for this nice talk. I'm gonna please put your questions in the Ring Central or in the Q&A box. One question is from Rael Bellis from Novo Nordisk. Is an oral GLP-1 available in the market? What is the advantage of your GLP-1 formulation in comparison to the currently available oral GLP-1?
Wonderful. So the GLP-1 in the market and the GLP-1 we are making is a little bit different. In one of the slides, we show that the GLP-1 we are using is actually the plasmid DNA. So in GLP peptide was encoded in the plasmid DNA to enhance their half-life, so that you kind of control their dose frequency. And also in the in vivo study, you'll see that our formulation actually is given like once in 4 days or 8 times in a week, and still been able to maintain the blood glucose level, so that we can say this has a sustained or controlled release profile, which is comparatively better than the Novo Nordisk one.
Nice. Let me see if there are other questions. I'm not seeing other questions, but another question would be from me. So you're focusing on the lipids coming into your blood using, the burgers and other things. I just wonder, obviously it leads to cholesterol and cardiovascular diseases, other things. There is a big trend in using some medication to lose weight. Are you looking any of those, like some kind of blood cleaners or some kind of drugs you can take to lose weight? Because that's a way to treat obesity, perhaps.
Right. So when we submitted this paper to PNAS, and got accepted. But we got like a very nice comment from the reviewer that they wanted us to address, like, one of the things is the leptin, which is they want to see if the ionic liquid has any interaction with the leptin pathway. So that's the one thing. And the second one is probably to answer your question is the blood cleaner. So we don't see the case with the fat that goes to blood. But if you see the other paper published in PNS with the insulin delivery, they goes to blood. So I think the choline itself in the body, and they're playing the different rules in the body in naturally. So I don't know if we can increase the blood concentration of the choline or uronic acid, and that could be helpful to kind of capture the cholesterol from the blood and pushing out some way through the kidney or other excretory system. But I think that this is a great question, and that's give us new the thinking capability of expanding this project beyond.
Thank you. There's another question. These anti-diabetic drugs could be used for which kind of diabetes mellitus? What's the mechanism of drug release?
Well, so GLP-1 for sure is type 2 diabetics, but insulin could be used for type 1, but that also used for type 2 diabetics in clinic, doctor prescribing in many cases. So the drug release mechanism is, so in this case, especially if you're talking about the GLP-1 delivery with the heparin and bile acid transporter. So the bile acid transporter, bile acid is in our body. As I said, like there are a few milligram to gram of bile acid circulating in our body in every minute. So they goes to the liver, and then liver do the metabolism of the bile acid and heparin. So we are using heparin because it's also a FDA approved molecule, and it is in the clinic for maybe 50, 60 years, and still there is no alternative of heparin for anticoagulant purpose. So both of the drugs are actually metabolized in the liver, and that actually kind of helps to release the drug in the liver, and then those GLP-1 could circulate to the body and find the right part, the right cell to be able to increase the insulin secretion whenever or as per needed.
All right, another question is it necessary to use continuous blood glucose monitoring in this method?
Yes, so if you are talking about the GLP-1, so the main purpose of GLP-1 is treating diabetics, and the only way you can monitor the treatment effect is monitoring blood glucose. So yes, you have to monitor the blood glucose level continuously to see if the drug is working. But if you're talking about the case ionic liquid to treat the obesity, no, you don't need to monitor the blood glucose level. But we did here just to kind of generate enough data to see to provide the PK and PD. But if in real-time application, you don't need to do that.
I see. Great talk. I was wondering if there are any commercially available medications to prevent the fat absorption from GI tract, like the cage system can do.
Yes. So as I said, there is 2 drugs FDA approved right now. So one is orlistat, another is loriqx. So they are for that treating obesity. Especially they kind of excrete the fat molecule through fasciculation, which is a different mechanism than our mechanism. So our mechanism is to capture the fat that in the food. We are not taking any fat that already existing in the body, right? So there is a significant difference of the mechanism and application of those FDA approved molecule and our molecule. So again, our molecule is actually kind of preventing your body weight increment without controlling obesity. That means you can continue barbecue, cheeseburger and all the fatty food you want, and just take maybe 1 capsule daily, which is gonna be maybe 250 microliter, and then that's gonna kind of capture all the fat molecule and removed from the body. So you don't need to do the keto dieting, or you don't need to do any dieting things in our case. But still it's in animal, in experimental condition. We did only in the rat, but still long way to go.
Wonderful. So this is Ali. I just want to thank you once again for this wonderful talk. And, it's amazing all the great things you've done in a very short time. So thank you very much. And I'll turn it back to Mehmet.
All right, Ali, thank you so much for being a great mentor and motivational, inspirational figure.
Again, thank you, sir, for the nice talk. There's all the questions I have. Appreciate, and you should come visit us sometime.
I'm super excited and looking forward to do that.
Thank you. Have a nice day.
For your time. And so there's one question I got, I think, from Amy Abdul Malik. Can we receive a copy of the recording, please?
Samantha, can you post the link on the site? I believe it's available on the Terasaki website.
Okay, I'll send it out.
Yeah, thank you so much.
Thank you, Mehmet. And thanks to the audience, and thanks for the nice questions. I really enjoyed this presentation, being in a office room without seeing any audience in front of me.
Yeah, thanks. Have a nice day. Bye-bye.
Thank you. Thank you.